Today I am presenting the findings of a study we did comparing VQ SPECT Lobar Quantitation using our program, which we term Royal Adelaide Hospital VQ SPECT CT Quantitation, or RAH VQ-SQ for short, versus a modified version of a commercial quantitation program from GE called QLung. For the purpose of this study, GE kindly provided us with a temporary QLung program license for free without financial interest. Our study has been approved by our ethics committee. VQ scan quantitation has a clinical role in the preoperative assessment prior to lung volume reduction surgery or lobectomy. The current standard VQ quantitation test is planar quantitation with two lungs being segmented into 6 zones, which is clearly not physiological as lungs are not neatly packaged into 6 neat boxes. My collaborator Ben Crouch has designed an IDL-based software to perform 3-dimensional lobar quantitation. This program fuses lung CT with VQ SPECT. The CT is displayed as a 3-dimensional map for the operator to annotate the positions of the fissures. The program then fuses the segmental CT map to the V and Q SPECT datasets, thus allowing lobar quantitation of ventilation, perfusion, and volume. For this presentation, I will call our program RAH VQ-SQ. The result is a spreadsheet like this, depicting the percentage volume, ventilation, and perfusion in each lobe. In a study we published in 2017, we demonstrated that RAH VQ-SQ as a program for lobar quantitation of ventilation, perfusion, and volume is reproducible with good inter- and intra-observer concordance between 3 readers. We then devised a novel approach to the data analysis for the purpose of determining degree of lung damage in emphysema. We derived an index we termed Ventilation Perfusion Differential Index, or VQDI, which is a product of concentration of technique gas and concentration of MAA for each lobe. The product reflects the achievable air-blood concentration for the volume of the lobe that it occupies. The lower the index, the worse the emphysema. In a study we published this year, when treating patients with advanced emphysema with bronchoscopic lung volume reduction using endobronchial valves, we showed that choosing a lobe to collapse based on VQDI had a high concordance with the gold standard test of quantitative CT. A further novel approach with our program was to derive another index we call Ventilation Perfusion Capacity Differential Index, or VQCDI, which is a sum of products of ventilation and perfusion of all voxels in the lobe divided by lobe volume, which gives an assessment of amount of air and blood per unit lung volume to estimate differential lobar contribution. The lobar differential volume from the CT map, or volume percent, also has potential value for differential lobar contribution, but without VQ. In a small pilot study, which we are presenting as a poster, we showed that using VQ-CDI and volume percentage, we could closely estimate post-lobectomy lung reserve. The actual post-lobectomy measured FEV1 and DLCO closely resembled our estimates from preoperative measurements. The fundamental question, though, is, are we measuring what we think we are measuring? There is no gold standard for lobar quantitation. However, there are commercial programs that have been certified as medical devices. One such program is QLung from GE. In this program, the operator annotates on a 2-dimensional CT map in the sagittal plane where one thinks the fissures lie. The program's artificial intelligence then finalizes where it thinks the fissures are, and the differential percentages of volume, ventilation, and perfusion are determined. So our aim is to assess our accuracy by showing concordance with an FDA-approved commercial program, GE QLung. We used the data from our bronchoscopic lung volume reduction study. Data from 19 subjects were analyzed for ventilation, perfusion, and volume percentage for each lobe using RAH VQ-SQ, all processed by me for short. I will call my results RAH in blue. GE kindly provided us with a modified version of QLung that can analyze VQ SPECT data from GE Hawkeye 4 and a separate CT. The data were analyzed using QLung by 2 technologists, done independently, blinded to the clinical data, my results, and to each other's results. Their results I will call Q1 and Q2 for short. To evaluate the concordance our results, we use intra-class correlation coefficients. For strong concordance, we needed to have a coefficient of 0.6 or higher. The mean difference between pairs of measurements were also determined using the Bland-Altman limits of agreement method. The closer the difference to 0, the higher the concordance of the 2 measurements. Here are the raw results at a glance. Ventilation on the left, perfusion in the center, volume on the right. Each graph with percentage of each of the 5 lobes as per analysis by me in blue, Q1 in red, Q2 in green. the spread of results between the three analyses for the three parameters visually appear concordant. Here we have the ICC for ventilation percentages, with paired comparisons between the three of us with datasets for the 5 lobes depicted in different shapes and colors. Concordance is perfect if data points show y equal x with a 45-degree slope. The data are not perfect, but close. ICC for RAH versus Q1 and versus Q2 are 0.71 and 0.69, thus strong concordance. ICC for Q1 versus Q2 is 0.97, thus very strong, implying QLung is a highly reproducible program. The paired limits of agreement test show mean differences close to 0, indicative of good concordance. The Q1 versus Q2 plot on the right appear more sparse, but please note that the y-axis have a narrower range and values are about a quarter of the other two plots. Similar ICC were noted for the perfusion percentages of the 5 loads between the 3 analyses. Strong concordance coefficients between RAH versus Q1 and versus Q2, very strong for Q1 versus Q2. Mean difference close to 0, indicative of good concordance. ICCs for volume percentages show strong concordance between RAH versus Q1 and versus Q2, very strong for Q1 versus Q2. Likewise, mean difference show good concordance between the 3 analyses. When processing the QLung, I asked the 2 technologists to record any technical problems. This table outlines the problems encountered and in which subjects. The problems were noted consistently by both in 10 datasets. The nature of the problems were very similar, relating to deficient fissures and the program localization of fissures being incongruent with their visual assessment. Among these 10 datasets, only in 2 subjects were Q1 and Q2 discordant with RAH. Despite technical difficulties in all the other datasets, the 3 analyses appear reasonably concordant. When the troublesome data points were excluded, the ICC got better. For ventilation, RAH versus Q1 went from strong to very strong. No change in the other 2 ICCs. There was no significant change in the limits of agreement after exclusion. For perfusion, ICC for RH versus Q1 improved from strong to very strong. No change in the other 2 ICCs. No significant change in limits of agreement. Likewise, ICCs for volume also improved from strong to very strong for RH versus Q1. No change in the other 2 ICCs. No significant change in the limits of agreement. To prove accuracy of our technique, we chose to prove concordance with QLung, which is a commercially available program whose accuracy has been verified by the FDA. In QLung, my collaborators found technical difficulties relating to cases with deficient fissures, when lows were badly scarred, collapse was simply absent, with the inflexibility of the program, when the CT window was not adjustable, and the limitations of the 2-dimensional display. With advanced emphysema, tears develop in the fissures. The 2-dimensional display of QLung with no ability to manipulate the CT window makes guesswork of the position of the fissures, which is addressed by the artificial intelligence of the program. However, the program does not always get it right. In this example, the oblique fissure is determined by QLung was clearly incorrect. RHBQ-SQ provides a 3-dimensional CT display which is freely rotatable and CT window adjustable. This example has a badly deficient horizontal fissure. Manipulating the window, one can see the position of the fissure but the absence of vessels. Confidence in fissure localization is enhanced by being able to rotate the 3-dimensional images. The final step, the program color codes the lobes for a quick check. The results of our study show that there is a high concordance between RAH-BQ-SQ and QLung. Just to be sure, concordance was confirmed by comparing QLung analysis by 2 independent operators who arrived at very similar results. Thus, we also proved the inter-observer reproducibility of QLung. To test the robustness of our concordance, we used data of patients with end-stage emphysema. A stronger concordance is expected if there were less scarring, as evident from the high ICC scores when the troublesome data points were excluded. So in conclusion, our study appears to support the accuracy of RAH-BQ-SQ for VQ SPECT CT Lobar Quantitation by showing a strong concordance with duplicated data analysis using the commercial program QLung. Thank you.